Well, it looks like it's 7 over here, so I think we'll get started. So first, just welcome to everyone, and especially to the speakers for participating in this Society of Thoracic Surgeons Instagram Live. We're going to be discussing the first 100 days as an attending. So it's applicable to cardiothoracic surgeons, other surgeons, probably other students and residents. So a lot of great tips and advice on how to succeed in early career. Um, in a few minutes, I'll have the panel introduce themselves. Um, this is new for us as Society of Thoracic Surgeons and STS, but I think a little bit description. We're going to have some conversations. Feel free to add comments, questions, agreements, disagreements into the panel or the comment section. I've gotten a few requests for the audience to join. Unfortunately, we're not having audience join as video participants, so it's just going to be the 3 or 4 of us speaking, but audience members can be engaged and involved in the conversation and in the chat. So I guess I'll start with introductions. My name's Rob Van Haren. I'm a thoracic surgeon at University of Cincinnati. I'm in my 7th year in practice. I'm involved in our residency. I'm the program director. We have an integrated thoracic residency training program. I think I saw a couple of our trainees sign on, so thanks for joining. Hi, guys. And kind of really interested to talk about how to succeed as an early career surgeon and get going. Dr. Brownlee, you want to introduce yourself?
Yeah, thanks so much. I'm Andrew Brownlee. I'm a thoracic surgeon at Cedars-Sinai. I am Associate Program Director for the Cardiothoracic Surgery Program, as well as General Surgery, and I will be finishing my 5th year as an attending this September. I'm happy to be here, and thanks so much for the invitation. This is a great platform.
Yeah, thanks, and thanks for coming. And Dr. Hosseini, you want to introduce yourself?
Yeah, absolutely. Hello, I'm Motahar Hosseini. I'm a cardiac surgeon at MGH in Boston. I am in my 2nd year of practice, almost entering 3rd year in a few months. I primarily do cardiac and aortic, and not involved in that way that you guys are involved in the residency or fellowship program, but we have residents and fellows, and I love teaching, so I'm involved in that. But otherwise, I'm happy to be here. Thank you for the invitation.
Yeah, thanks for joining, and don't worry, your careers, it sounds like, just getting started, so you have plenty of time to get involved in the education pathway, or all those other opportunities.
Absolutely.
And yeah, and that's kind of what we'll get to that as well, as kind of how to take on new roles and how to keep growing and still trying to get going. So like I said, Dr. Antonoff, I think, will be joining us later. We'll probably pause when she gets in. I'm actually going to make sure I'll re-invite her in a minute. But yeah, so thanks everyone. Really appreciate everyone's coming and watching and joining us. We're talking again about the first 100 days as an attending. So whether it was 6 years of training of an integrated residency, or I don't know, maybe almost 7, 8, 10 plus years of general surgery and fellowship and research and everything like that, eventually there's end of the rainbow. At some point, you're done with training and you're starting your real job. And it's a stressful time, and there's a lot of things that hopefully we'll discuss, that best practices that people can learn about, and how to be successful from kind of really day one. So maybe start with Dr. Brownlee, but kind of the first question that we kind of had out for the group is, what strategies have you found most effective for establishing a safe and sustainable surgical practice during your first years as an attending, kind of focusing on our core of our job, like operating, taking care of patients, how to be safe and how to be successful and sustainable?
Well, I think this is probably one of the most important questions and a great selection. When you finish your training, you're going to come into your new job wanting to prove yourself, I think, wanting to make your mark. Particularly if you're going to a place that you've not trained and you're not familiar with the faculty and the institution, and you have a lot of energy, you have a lot of skills, and you're also, probably very comfortable doing complex cases, skin to skin. I think it's important when you get somewhere to really, you're never going to have more time than when you arrive at an institution. It's unusual for you to hang the shingle and then have sort of a full clinic the following week, although it does happen. And so with that time that you have, I think it's important to settle into your institution, get a sense for the resources you have. So I think it's important to understand, what are the strengths and limitations of the place you're going. Try to spend as much time as you can in the OR, scrubbing or watching cases with your partners. Understand the workflow, the referral patterns. Also understand, again, the limitations of the institution that you're at. So what are their strengths and weaknesses?
We may have lost our audio for you there. Yeah, you're back. But
Okay.
yeah, I think, like you said, I think in the beginning, especially, really just getting to know people, starting collaborations with people in your group, your partners, but even collaborating physicians or researchers or whatever it might be. It's a good time to make connections. I think is part of it.
Yeah, and even just anything down to when a robotic lobectomy is being done, are the thoracotomy instruments open? Where are they? Little things so that if you do have a challenging situation, that you sort of know the workflow to manage it. Spend some time with your partners, understand the ones who are perhaps more on site at that campus that you're at and can be available to help if you need them, if you're going to call them and need them in the OR. And I think also just in closing, to answering your question, is really come in, I think, understanding your value. So we just have two junior attendings who just started within a year, and they're both absolutely phenomenal. And they're coming from MGH and from Mayo Clinic, and they bring an immense amount of sort of experience and knowledge in seeing how things can be done at another institution. And so a lot of the time when we're operating and they're spending time with us in the OR, when they're not doing their own cases, we're really discussing how our techniques differ, and they're obviously bringing a lot to the table. So just understand, although you're coming in and you're seeing a lot of things for the first time and you're trying to get to know people, and also understand your inherent value as a new attending.
Yeah, that's a good point. Dr. Hosseini, how have you done it in your early career in terms of maybe case selection, and then the other aspect is as we already talked a little bit about, but working with senior partners, or booking a case with a senior partner, and those kinds of decisions, who to operate on, and if you need help, or if you need to know if someone's around, or just schedule it with someone. Any thoughts on that, or the
Sure.
topic in general?
So, I'm going to focus obviously on the cardiac side. I think at least for the cardiac side, it's a little bit different just because of the, depends on where you have been trained, the autonomy you've gotten, and, it's just a little bit, I think, different. So when you come in as a new attending, it's a good idea to just start with familiar cases. You want to start doing cases that you really have done a bunch in your training, and you've done the cases yourself as a first, primary surgeon. You don't want to do your first few cases in the first few months, the cases that you've seen only 3 times during your whole fellowship. So that's usually what everybody, when I just started, that was the advice I got. Really think about the case that you're getting, and do a good patient selection. Now, it's a little bit difficult because when you start, you don't really have an outpatient practice. So everything that comes your way is inpatient consult. And usually inpatient consults tend to be, those patients are sicker, they're more emergent, their endocarditis, their STEMIs, their NSTEMIs. Those are patients who have poor targets, the patients that cardiologists are not touching. So it means that, those are sicker patients. So you're getting to do sicker patients, but still, at least in that, sicker population, you still can use your judgment and think about it. And the other thing is that as a new attending, judgment is a little bit different when you compare your judgment with a senior partner. You might think, okay, this is a case I can do. I've done a bunch of Bentals. I know how to do root replacement. This is endocarditis. Sure, the patient is sick, but they're young. But then when you talk to your senior partner, they say, oh, have you looked at this? This patient's liver doesn't look good, or that AI does, the LV. So there are things that they tell you, and you realize, oh, yeah, they're right. I should have thought about that. So I would say first to start with familiar cases, but also really build a network of people you can go knock on their door and say, hey, what do you think I should do? And that person can be either a very senior person that you can knock on the door and say, hey, what do you think? What is your advice? I'm doing this double valve endocarditis, very sick patient. Would you be able to help me with the case? Or it could be a person who's just a few years older than you and you feel very comfortable with, and you can go sit down in their office and say, hey, I have this case tomorrow. Can you look at the cath? Can you look at the CT? And let's talk about the case throughout from the start to the end. And that person can tell you this can go, this can happen, that can go wrong. So I think that's important to really know who can be your mentor, and that mentor can be a junior person, just a few years older than you, but they have more experience, and they also can tell you a lot of other things. You should ask this person to help you with this case, because for this case, this person is better compared to that person. So a lot of value comes with knowing who you should go to and talk to. And then the third one I would add is preoperative planning. I cannot emphasize enough how important it is, because as a junior attending, when you start, there are things that you did not think about when you were a fellow, because the attending was thinking about the whole thing, the whole room. They were managing the room. You thought you were a good fellow. You thought, oh, I know everything. I can talk to perfusion. I can talk to anesthesia. I can manage everything. But as a new attending, there are a lot of things that are on your mind when you're operating. So thinking about it, having a good preoperative plan will also help. So that's really how I started. I took the advice of other people. I knew who to ask help from, especially the first, I would say, 3 months. You really want your cases to go well. You don't want to have mortality. You don't want to have big complications. So it's good to have someone be available. At least you can also, if you know there is a case that is marginal, you can say, hey, are you available tomorrow? Where you at? I'm doing this case. I just want to know if I didn't find this target, for example, would you be available to give me a hand? So it's just a lot of preoperative planning, a lot of talking that will help.
Yeah, I think those are all great advice and great tips. And like you said, a lot of preoperative planning. And yeah, I love the strategy too of, taking the case to a partner or senior faculty member and asking about the decision making and what you should do. And then it's always a nice segue to be like, oh, and by the way, are you around tomorrow to help or whatever it is, to kind of after they've reviewed the case with you. And because I think that's the other important part, like you said, both of you guys said, really, it's like leaning on senior partners to help out, either in the decision making or to just the comfort of knowing someone's around in case the case turns challenging. Kind of having a sense of that, like you said, who's on campus or who's next door, and if in case you need a hand, that's really helpful. And a lot of it too, you guys mentioned and kind of get the sense that, at least I did. My first job isn't where I trained, so first day is like a new institution, and yeah, so a lot of that is learning where to go, who the people are, what people's names are, and someone I think in the chat said like what not to do on the first day, and I would probably just say just be nice to everyone you meet, and that's probably the most important thing on the first day. But yeah, so I think
Yeah.
those are all good strategies.
Yeah, great point. And I think, I think your demeanor when you start is really important. You don't want to be sort of, forgive the term, but just, lighting a fire or dropping bombs, and getting people upset. You really want to try and engender good relationships with your physician assistants, with your colleagues, with your referring providers, with the nursing staff and the techs in the OR, and that just that sort of builds a trusting relationship. And it actually, up until a point, I think obviously, people do get stressed and things can change on a dime. But if you have a good relationship with all those people, you're gonna be in a safer working environment, where everyone's comfortable to sort of speak up and support you. The other thing too, just to add, is I think go and understand how the cases are done at your institution, and understand what are your sort of hard yeses and nos in terms of what you need as a surgeon versus how much can you be adaptable in sort of trying to copy what's done at the institution you're going to. So, for example, if you do things very differently in the OR than the rest of your colleagues, and you're coming to an institution where they all do it a certain way, you have to understand there's a balance between your needs and sort of the comfort of the OR team, and there's a balance in there that is the safest. So to go to a new institution and say, I want all these things and I need this instrument that is no one's ever seen before, no one knows how to use, all of a sudden the OR staff is less comfortable than when they're doing cases with other people, because their learning curve all of a sudden is shifted and they're focusing on different things. So just little things to be mindful of, I think. You kind of have to understand what are your absolute musts, absolute needs and don't needs, and don't die on every hill in terms of trying to change things where you're going.
Yeah, that's a good point. And the other one that was made earlier, which I agree, and again, is case selection and starting simple. I think as even the first 100 days, just if there's a faster, simpler way to do a case, probably it's better early on. Like you said, you really want good outcomes for patients first of all. Obviously, you want great clinical outcomes, but even for yourself, and to generate confidence in what you do. And then also too for the other people that you work with, so that they have confidence in you and help build relationships and respect. So I think that's all great stuff. The next one, and I guess kind of switching gears to our next question, and maybe Dr. Orsini, I'll throw this one to you since we kind of talked a little bit about it. So kind of like leadership, like your first 100 days, you're just starting, being an attending, trying to figure it all out. And is it too early to be a leader, or are you a leader from day one? How do you navigate that, and how do you step into leadership roles later on? What's your take on being a leader as an early career surgeon?
So that's a really good question. I think as a very early on junior attending, your whole focus is on how to grow clinically, how to be safe, how to build a practice, how to build relationship with people. And when we talk about leadership, I think at least at that very, very earliest stage, in my opinion, we're talking about just leading your team, your clinical team. And, that's kind of there is a fine line there. You don't want to come off as, this person just started, they're telling me what to do, what not to do, because especially when you go to a new place, every place has their own protocols. Every place has their own, pathways, culture. So you have to kind of navigate that. But overall, when you're, for example, in the operating room, you're leading that team. You're leading the whole team of the perfusionists, the anesthesiologists, the OR staff, your fellow, your residents. So I think, to me, that's probably the most important thing, as so early as, you know, the first few months of you're starting your first job. And it takes time to feel the confidence. You know, you want to say the right thing, you want to do the right thing, but also you want to listen to other people. If you're doing something and anesthesiologist tell you, hey, why wouldn't we do this? Why, like, we should maybe consider, you know, for example, Impella versus ECMO or something like that. It's not a bad idea to just listen. It's actually a good idea to listen and discuss. You don't have to be the person who, that doesn't mean you're a leader. You don't have to be the person that, no, I'm always right. I have done this training. I'm coming from this place. I'm right. I'm the person. I'm the surgeon. Discussing with them, getting to know them, you know, having a safe discussion is all part of it.
Yeah, and like you said, I think like listening is a big part of being a leader, and like you said, it's important. Something probably sometimes maybe hard to do, or especially you're distracted, and but yeah, I think that's really important. And I agree. Really, from the beginning, you're a leader of the clinical team in the operating room, and then also too, you're going to be leader of you know, the in some ways of the office or your clinic, and how is your clinic managed. And that's also a little bit of a struggle as a new attending and faculty member, is kind of organizing all that stuff that you really, as a resident, you focus on taking care of patients and operating. But now people are asking, well, how long is clinic, and this, that, and these kind of details that you never really even thought about. It makes it challenging to figure out some of those questions and answers. Um, yeah, so Dr. Brownlee, you have some, you know, leadership roles, and you're a few years into it. So when did you start saying yes to those opportunities, and were they things you wanted to do from the beginning, or kind of things that evolved over time?
Well, I think I wanted to do all of it from the beginning, but I think the concept of of, you know, focusing on your clinical practice and your development early is really important. And just to have everyone understand, those leadership roles will naturally come, and opportunities will present themselves as you go along. It's very hard to say no when an opportunity is presented to you. I think, you know, weighing the risks, benefits, alternatives of taking on a role is important, but it is hard to say no. But usually those roles, or at least large, time-consuming roles, are not sort of presented to you in your first 100 days or your first year, but they do come over time. And I would just assure everybody on this, and I'm sure you both agree, you know, as you start to get to that 5-year range, you've got plenty to do and plenty of leadership roles, and probably you know, just barely enough time to get everything done. And at the beginning, it's much more important to be building a foundation for your clinical practice, and that's making sure that you understand the workflow, that everything is safe, that your cases are going well, that you're developing relationships. All of that is so important at the beginning, and that should be, because when you start, that's the time you'll never have more time in your career than in those first 100 days to build that foundation. And the leadership stuff comes. It's rewarding when it comes. Of course, it's time consuming, but I just would not recommend openly going out and seeking it out right away. I really agree with what everything that's been said so far.
Yeah, that's a good point. And like you said, you know, again, we're surgeons, we're cardiothoracic surgeons. Got to keep the main thing the main thing, and operating, taking care of patients is really, you know, the what we love to do, and we got to really focus on that, so those outcomes are still great. And then, yeah, over time, those other opportunities and leadership will come. It's funny as we're saying that I'm trying to get Dr. Antonoff to join. I guess she's still busy because I was going to put a plug in for her program and that she's been involved with several years and some of the other people on the call. But the Society of Thoracic Surgeons has a leadership academy. So if you're interested in learning skills and experiences from leaders in our field, it's a program that I was involved in a few years ago, and I've helped moderate a couple sessions lately, and I know a lot of people on the call are involved as well. But good opportunity and a good plug for stuff that the society does to help early career surgeons. I don't know if you guys have been involved or aware of that, but
Yeah, absolutely. It's a tremendous program, and I think it's sort of the long form discussion of what we're talking about here, and just I think a really important thing to consider.
all right, cool. Well, we have some audience questions, so I might get vetoed off this forum next time if I don't listen to the audience. So we'll take a pause and we're gonna answer a couple questions. So this one is from Lamar Moe. So being an attending at your institution that you've trained before, how do you? So I think so. If you stay at the same place, how do you change your previous image as a resident and become a smooth transition? Any advice to change previous habits? So I think the question is, you stayed at your same place. How do you transition from a resident into attending and have other people, I guess, respect and think of you as an attending at the same institution? Any thoughts on that?
Um, I can go with this one. So, well, I moved, so I don't have a personal experience, but I think the best way to go about it is not to push it. Just let it be. You know, at the beginning, they're gonna think of you as their junior, as their resident. The staff or staff, everybody has been like, you know, you've been the resident, you've been the fellow. They're gonna think of you as their, you know, buddy. You've been laughing with them. You probably hung out with them in the past. Um, I think as you just let it be and let everything play out the way it's supposed to be. Just focus on your work. Don't make people stop calling you by your first name all of a sudden, your first day of it being an attending. Just, you know, allow everything to be the same. But slowly, as you build your practice, as you become more confident, as you have good outcome, as you show your how good you are and how skilled you are, people start changing, you know, their vision. People start thinking of you. They come to you to ask advice. They ask you for your help in their cases. The or staff start seeing you differently. So that's I really believe that's probably the best way to do it, because I don't think there is any good way around that.
Yeah, I think that sounds good. Yeah, again, I didn't have experience with that. I went to a new place. Sounds like Dr. Brownlee, you did too, but yeah.
Yeah, I mean, I think that's the perfect answer. I mean, there's benefits and drawbacks to staying at your own institution. There is that familiarity that you don't have to, that hurdle you don't have to cross of going to a new institution, getting to know everybody. But I think the trade-off is just that you know, you have an image that you develop there as a trainee, and it just is going to take a little longer for that image to sort of shift, and you mindfully build it over time with your effort, your hard work, your technical abilities, your communication. But it's certainly not something you want to try and force.
Yeah, I think that makes sense. And then the other question that we had from the audience is about kind of working with residents as a early career surgeon, either at an academic institution or maybe a community program that works with residents. How do you balance training residents and focusing on your own growth, and also I would add like patient outcomes as an early career surgeon?
Well, I think from a thoracic standpoint, when you start as an attending, a lot of the cases you're going to be doing, at least in the first few months, are inpatient, perhaps a high acuity, but usually it's sort of perhaps decortications, biopsies, and a lot of those cases, a decent amount you can do with a trainee. I think when I started, and I still work on this, I'm trying to be mindfully present about the amount that I let the resident do is really the amount that I am personally comfortable with, and if something goes wrong, then I can manage myself, and not just sort of giving certain components because that's sort of my reflex. Okay, I'm going to have you do this, the infrapulmonary ligament, and then I'm going to have you staple the vein, and I'm going to have you staple the artery. Really want to, step by step, just with a knowledge of the capabilities of the resident, just let them do the portions that I'm comfortable handing over. Dr. Antonoff, how are you?
Very good. Nice to see you all.
Hey, Dr.
Hello.
Antonoff. Thanks for joining us.
My apologies for joining late. I know you guys are probably having a fantastic discussion already.
Yeah, it's been good. So yeah, we talked, just I guess to recap, and then we'll have you maybe give an intro on who you are. But we talked about, as an early career surgeon, first 100 days, how to have good clinical outcomes in the operating room, so like case selection, leaning on senior partners. And then we just talked about leadership and how even early on you're a leader of a clinical team, and then you start developing leadership responsibilities as the years go on, and whether it's a clinical pathway or a clinical program or an education or research, and how to kind of be open for those opportunities. You want to take a couple minutes just to introduce yourself to the audience?
Yeah, absolutely. I'd be glad to. My name is Mara Antonoff. I'm a thoracic surgeon at MD Anderson Cancer Center in Houston. I have been in this position for 11 years, and this was my first job out of training. I have a practice in thoracic oncologic surgery, yeah, that includes elements of research and education as well. I'm also the program director for our fellowship program. And I 100% agree with everything that you just mentioned in terms of, getting the ball rolling and how you start to practice, the importance of leaning on partners. Certainly, I feel very privileged to have entered a practice where I have a lot of senior partners, and there are folks that you can ask questions of, and lots of resources and support. But I think that's probably the most important lesson for people in their first 100 days of practice is really not trying to do it alone. And whether that means looking at your partners in your new practice, or calling previous mentors from training or colleagues, just recognize that, this is a complex job that we all do, and no one should be trying to do it alone. And we don't do it alone. Like you said, we're leaders of a huge team wherever we are, whether we're in the operating room, on the ward, in the clinic, in the office. There's always a ton of folks that we are working with. And leading a team doesn't mean that you're the only one that makes the decisions or influences the decisions or the outcomes. So I think all of those concepts that you've mentioned really tie together very well, in that we are part of a huge team and everyone's input matters. And even as the leader, we have so much that we can learn from those around us, with a really steep learning curve at the beginning, but it continues for the rest of our careers, that we need to continue to learn from all the people around us, and to ask for help and support from those who are more senior, more experienced, or just for another set of eyes and ears. So I think all of the things that you're discussing are kind of like hit the nail on the head as far as my thoughts about the first 100 days of being a practicing attending in thoracic surgery.
Yeah, well, that's great. And again, thanks for joining. I agree. And even to one of the things you mentioned, I think I would echo is, we talked about senior partners and things like that, but the people that you trained with, or the co-fellows, are a great network and a great resource of, they were your friends, or they still are your friends. And they're going through similar experiences. And at least for me, that was like a big support system, and still is, about cases or problems or different things like that. And it's a good way to stay connected. And I still, talk with my co-fellows pretty frequently. So it's a good resource. Doesn't always have to be the most senior person to give advice or to help you through things. So that's a good point. I guess Dr. Antonoff, you brought up, I think, in there as well, and it plugs into our third question about professional growth and kind of well-being. So, as an early career surgeon, you kind of just finished your training, but and you've already learned a lot. But how do you keep learning as an early career surgeon, and I don't know, just to stay fresh or to learn new things? And what are your takes on that, on how to continue to learn as an early career surgeon?
Yeah, that's a great question. I do think it's not just as an early career surgeon, but we all need to continue to learn our entire careers. But it's a big transition to go from training where every day you're expected to learn to being in practice, taking care of patients and making sure you stay on top of things. I think to some extent you kind of have to just be willing to pull it from every different direction, and that may mean when you're attending conferences that you're listening and asking questions and paying attention to what other people are doing. You're going to the video sessions and seeing how people do operations. But also, we all have our different ways of staying attuned to what the latest research is, what the latest publications are, what the latest guidelines are. And everyone kind of has their own way. Some people read, our journals cover to cover. Some people are looking for what's coming out on social media, which articles are being posted, on X or on LinkedIn, or what things that people are sharing. And I think everyone's going to have their own way that they pull the information. Many of us are fortunate to work in institutions that are multidisciplinary meetings, like art rounds or tumor boards or other activities where they can engage with colleagues. But I think the most important way to keep learning is not to just function in a silo. So whether you're in practice with a huge group, or if it's just you and one other partner, or even by yourself, practicing in a silo is where I think we stop learning, where we kind of just keep doing the same thing over and over. And so being open to understanding what's going on outside of you, the latest publications, the latest techniques. For me, one of the things that I did early on was that I did a lot of peer reviews of journal articles. And I found that for me to be a way that it was like my own continuing medical education. And I learned about what people were doing clinically as well as research. Like, it gave me ideas of what to do differently for my patients on whom I was operating, as well as different studies that I may want to conduct from a research standpoint. So that was something I did a lot of very early on. I don't do so many peer reviews as much as I did when I was a little bit earlier in my career, but I think that's a really good way to kind of just know like what's in the pipeline and what people are doing. And then, yeah, I think going to video sessions at national conferences can be helpful, but you have to remember that people put up videos of something they may have done 100 times, and they show you the time that it worked. They put up the weird things they do, the uncommon things that they do. And really, those first couple of years of being a faculty member, you just want to do safe operations. So you just have to understand that if you're looking at these videos at the meetings, they may not represent the day-to-day practice. They may be kind of oddities. So be careful about how much weight you put into what you think. Oh, everyone's doing, robotic pneumonectomies with the patient who's not intubated. Like, that's not happening. It's like it's an isolated, strange event. So I think just being open to taking input from every single direction and trying not to function in a silo. But I do think it's going to be different depending on each practice and where you're at. I don't know. What do you guys think about that?
Yeah, I think good points, and agree. You have to be a little bit careful on, yeah, conferences or social media with videos. And again, just doing the safe thing and the right thing for you and for your patients. And just because, and I think it was tonight, there was a video posted on Twitter of a robotic left upper lobe and PA plasty and intrapericardial all done robotically. Doesn't mean that, maybe that's the right thing for you in early career and things like that. Dr. Husseini, any thoughts kind of on cardiac and continued growth for you, and whether it's clinically or other areas in your career?
Sure. So I think I have a couple of advice. First is that, at least for me, when you're so new, like 1 year or 2 year in your practice, all your focus is clinical. You want to build a practice. You want to know as many cardiologists as possible. You want to have good outcomes. So I think to think about the growth is professional growth is very important, and probably one of the good ways to do it is to really dedicate admin time to it. Say to yourself, I'm going to have 1 hour per week, I'm going to sit down 2 hours per week. I'm going to sit down and read a paper, watch a video, think about what I can do, look at what meetings are out there, or talk to a resident about a research project I'm thinking, or think about other research projects. Because if it's not on your calendar, it's going to be very tough. And at least when here I'm working in an academic institution, I have an academic day, but a lot of time I pick up OR dates because that's exciting. That's what we love to do. And at the beginning, you might have to actually take that from your own free time. But as you become more experienced or more efficient in doing other things, then you can really dedicate more time to it. So I think it's good to really dedicate time to it. But also, I agree that you really want to attend meetings, at least one meeting per year. And I'm guilty of it when I'm thinking about, okay, I want to go to STS and I really want to go at least to one meeting per year. I'm thinking, okay, I'm losing one clinic day. How many OR slots I'm losing? I have to give up. What do I do with my calls? Things that is in your mind, how many dissections might come that I'm going to miss out, things that comes to your mind. So if you think about it that way, that, okay, that's okay, you have to go to at least one meeting per year, then that because going to meetings, as you said, you can watch other people, what they're doing, what are their most recent stuff in the literature, and what videos are there, what people are doing. So that's important. And the third one is to track your own outcome. And this is an advice I got from a friend who is a few years ahead of me. When I started an Excel file. You can get all those data, obviously. When you ask people, they can give you your data. But it's good to just, every case that you do, sit down, just enter your Excel file and think about it from the clinical standpoint. You also want to grow and think about it. Okay, how did I do last quarter? How did I do last year? And it actually is very fulfilling, because you can really see the difference between your bypass time, your cross-clamp time. You're becoming more efficient. You're doing more complex cases. Your outcomes, you can kind of think about it. I had this, I had that, what I learned. So just tracking your own outcome and really be a critic to you for your own what you do is also important for professional growth.
Yeah, that's great points. I think all three of them, and I agree. Dr. Brown, I get to throw it to you for your thoughts, and maybe also to have you talked a little bit about there, but maybe benefits of membership of STS, being an STS member, and again, we kind of talked about it, attending the meeting, and how that factors into professional growth for you or for others.
Well, I think membership is, I mean, all but essential if you wanted to sort of keep your finger on the pulse, literally and figuratively, of what's going on in the society. The meeting is a terrific opportunity, but there's a ton of additional online opportunities, podcasts, webinars, etc., and really gives you a sense of what people are thinking about and talking about around the country. I think that at the meeting, the presentations are always great. But it's really nice to see the commentaries and the discussions. That's where people are really delving down into sort of the minutiae of the decisions that we're making every day. So that's extremely helpful. I think I just want to echo the reviewing of papers. It's great because it really just gets your mind thinking about sort of the topics that are of great interest in thoracic surgery, which is, again, at the forefront sort of our field, is usually what's being published. And it also sort of gives you ideas about your potential research projects as well, just sort of stimulates that part of your brain. So I think all of those are really, really important parts of growing as an early surgeon.
Yeah, definitely. All right. Well, we're kind of wrapping up here. A couple questions in the chat, and then we'll then talk maybe final thoughts and kind of close. There, kind of housekeeping. Someone asked if this is recorded. I believe it is recorded, and I think we're gonna produce it into a content that can be reviewed and watched in the future. So look for that, and this is our first time doing it, so hopefully it all works, and that's going to be a true statement in a few days, and you'll see it online to kind of see this information. The other question that Dr. Okasanya asked us was, how should you go about understanding billing, coding, and reimbursement? So another aspect of early career surgeons. I know we're wrapping up. We could probably spend another 3 hours on
Yeah.
that topic, but I don't know. Does anyone have any good advice for that aspect of early career?
I would suggest that you, if you're trying to understand billing and coding, that you speak to two different individuals. One being like a billing and coding specialist at your place of employment, so they can really educate you on best practices and what the expectations are and how like what needs to be done. But then I would also talk to an experienced surgeon in your practice and ask them really like for the how they apply those rules and the day-to-day elements of it, because they will really understand the clinical nuances in a different way. So I would try to incorporate both of those perspectives in terms of finding out kind of what the rules are for the documentation and the billing and coding from the specialist who knows it really well, but then also trying to clarify um, the application in day-to-day practice from someone who seems to have their finger on the pulse of it.
Yeah, that's a good idea. We've started in the last couple of years having, I think it's like a 30-minute quarterly meeting with our coders, so the surgeons and coders, and sometimes we have an agenda or something we want to talk about, or but it's really just helped more than anything open up a dialogue. And now I know who they are, and even I think yesterday I emailed them about a case and like, hey, this was a little unusual. How are you going to treat it? Or did I do this correctly? Or then they'll email me, and it's not just a random request to fill out or to better document acute renal failure and in the note. So I think having that relationship has helped. So that's some advice as
Yeah, and
well.
I just to add to that, I think every institution is going to be a little different in terms of the amount you're involved in billing, and so I think it's important. The first 100 days is the perfect time to understand that and just get on top of it, because that's when you have the time to sort of delve into it and speak to the people at the institution and give you the advice, because you certainly don't want to be on the other side, which is 2 or 3 years down the road there's an audit or something and you come back and you've been doing something wrong, which is not a good look, and it should be entirely avoidable if you just do your diligence at the beginning.
Yeah, I think there's some key things that you should be aware of and find out from others what they really mean. So I think you need to understand what like a level 4, level 5 visit means. Like what's the difference between a new consult or a new patient visit? That's each of these different levels, 3, 4, 5. You don't want to undercode either. You want to make sure you're getting credit for the patient complexity and the level of decision making that is required. I think it's important for people who are early in practice to understand what it means for something to have modifier 22. Many of us know that for surgical procedures, modifier 22 means that it was more complex than the CPT code would typically describe. But there's certain language that you need to put in that note to justify it. And it's not hard, but you just need to know what it is. So make sure you understand what these different levels of billing are for outpatient visits and consults. Understand what a modifier 22 is and what type of language needs to be included to justify the use of that type of modifier. Make sure that you understand what type of language needs to be included for co-surgeon statements or having another surgeon with the same specialty in the same operating room. There's certain language that needs to be included. And it's not about gaming the system. It's about understanding the system so that you're properly documenting what you're doing and making it easy to be billed in the correct manner. And so just making it's really simple and straightforward. And for folks who have electronic medical records where you can create predetermined phrases or dot phrases, you can actually create for yourself like a list of, well, which of these elements led to this decision to add this code or this modifier, and just to make it easier for yourself. And since most people aren't super busy that first 100 days, that's really a great time to set yourself up for success by creating some of these templates and dot phrases to help yourself with predetermined lists that support your choice of billing and coding. I don't know if anyone has done anything like that, but I think it can be very helpful.
I think that's brilliant, and you're just reminding me of all the stuff I was doing. I mean, set up your billing, set up your op notes so it's much easier on a busy day to get them done. Make sure your epic is the way you want. Get the formatting right so it's easy for you to read and do notes. All this stuff that if you don't do it at the beginning, it's just never going to happen. So.
Yeah, and Dr. Mitzman reminding us here in the chat that member or a benefit of STS membership is the ability to submit coding queries to the coding workforce for complex cases or when coding is unclear. Thanks for highlighting that, Brian. So yeah, as I said, kind of wrapping up, it's been a great discussion of the first 100 days as an attending. I guess kind of any last wisdom to share on the group or final advice. We've talked a lot. Dr. Brownlee, maybe get us started. Anything else as
I
we
mean,
sign off?
yeah, honestly, I think we covered a lot, and the final thing is just enjoy it. It's an exciting time in your career. You're launching, it's everything you've worked for. So just with all the advice that we provided, heed it, but also be mindful and just enjoy the fact that you're starting your career as a surgeon, and it's going to be wonderful and fruitful, and just make the most of it.
Yeah, agree. Dr. Antonoff?
Um, yeah, I echo everything that was stated by Dr. Brownlee, and I think the first 100 days are certainly very important, but so is every subsequent day, and there are going to be ups and downs, and it is not a linear path. And I think the only thing you get comfortable with is your own discomfort, which is true of just about anything. You get used to the fact that as soon as things start to feel easy, there may be something else that hits you, and that's part of this job. And as stressful as it can be and as overwhelming as it can be, I think we really fail to recognize how very fortunate we are, how lucky we are to play such an important role in so many patients' lives. And I think the more we do this, the more we dwell on the hiccups, the challenges. But, I would say that a really important piece of advice to someone who's new in this field would be to say, any day you leave the operating room and you say, that was a really hard day, that was so difficult, I felt, like I had a really hard time, and the patient did well and things go the way you expected them to, rather than beating yourself up for having a tough day, realize we did something hard today. We as a team accomplished something that was difficult and got the patient where he or she needed to be. And that was the goal. No matter how hard it felt, the goal was accomplished. And I think that's the part, to be patting yourself on the back. We so frequently beat ourselves up when it feels hard. And what we should be doing is congratulating our teams for getting through something that felt hard and accomplishing the desired task. So I think, it's not necessarily going to be smooth sailing from here on out or at any point, but don't forget to celebrate the rewards. Every patient and every family member who thanks you for the contributions and efforts that you've put toward making their lives and their family lives better. It's easy to forget about all those grateful patients, but that's really why we do it. So that would be my piece of advice.
Yeah, great. And Dr. Hosseini, any last thoughts?
Yeah, I agree with everything that was said. I would say that everybody says that, your first year is the hardest, and that's true just because you're learning so much, you're getting to know new people, you're, getting to know so many new things that you even sometimes didn't think about it, like, for example, running a clinic. But it's also very, very enjoyable. It's very rewarding, and you do a lot of cases, you help a lot of people, so just enjoy it, and know that the second year will be much, much more fun.
Yeah, that's true. I agree. It definitely gets better every year as you progress. I think, like you guys all said, I agree with everything you said, and I think that one of the things to remember is we have a great job. Like, we're so fortunate to be cardiothoracic surgeons and to operate and to work with great patients and so many great team members. So it's a lot of fun, and I think, kind of like Dr. Antonoff said, remembering that and recognizing that's important. And then I think the other thing we didn't talk a lot about too, but I think maybe the other advice is, even in the first 100 days, take care of yourself and your own well-being, and work out, spend time with family, do other things. Don't, you know, that's important at the beginning, at the end, really throughout the whole thing. So I think that's another aspect to focus on as well. So. Well, thanks, and a big shout out and thank you to all the speakers for joining me tonight. This was a lot of fun to host and do, and kind of a new endeavor for us at STS, and hopefully it's something you'll see more of and it'll continue to grow. And thank you for all the audience members for their engagement and joining, and really appreciate it. Have a great night.
Thanks so much, everybody. Take care.
Thank you.
All right, bye.
Bye.